All right. Um, Hello everyone. Good to see you all. I hope it's beautiful weather outside today in Baltimore. So I hope that you all are enjoying spring. I have allergies, but I'm still trying to enjoy being outside. And just enjoying I find the sun to be very healing. And I also find healing from water as well, but so I really appreciate being outside. And so I just want to start there and saying I'm enjoying nature these days, and I hope that everybody's taking care of themselves. um it's the end of the semester. There's a lot going on in the world. I hope again you're just making time and space to do whatever you need to restore, and to again take care of yourself. And if there's anything that I can do or we can do as a program, please reach out. So I just have a couple of announcements, but before we get there, I want to begin as we normally do, which is inviting you all to lift up anything that you'd like to share with this community that we can celebrate. And as I always say, this isn't about bragging, it's just about facts, and we want to celebrate facts, and those facts are things that are happening. So whether it's papers, progress in your program, anything, feel free to lift that up. And so I'll pause and see put if what's coming in the chat, or if you want to come off mute and share, I invite you to do that as well.
I'm a little bit in a different place, I think, than a lot of you, but I'm a little late, but I finally defended my thesis. So it was good to get through. I was so nervous.
Yes, congratulations. And we are all on our own journey. So you are not late compared to anybody. You're right where you need to be. So I want to honor that and say congratulations. That is awesome. And I hope you see the applause, the celebrations, that the emojis that are coming up for you. Lots of love and congrats in the chat. So that's awesome. And thank you for sharing. And hello to everybody who just joined us. We're just making space to for people to lift up anything they want to share with this community. And we celebrate all milestones in our program. So okay. Anything else anybody want to lift up? I'm here. Okay. Well, while you are thinking of other things, I literally have one slide to share, actually two slides to share, before I turn it over to our guest for today. So let me go ahead and share my screen and just really have some reminders. All right, sorry, give me 1 second. All right. Share screen. All right, great. Okay, so I just have two slides for today. One is just a reminder, we only have one more time together after today. Like that's it, one more session. And then we're done until the Summer Institute, and then we'll spend some time together during that week. And then your time with me comes to an end, and then you move along in the program. And so I will be deeply sad, but we don't have to worry about that now because we have a lot of time. We still have a whole week to spend together in June. But we'll have one more session coming up. So as a reminder, if you've missed sessions, or if you need to watch something or sort of catch up, please take care of that, and just get those submitted to the portal by the end of May. If you have any questions if you can't remember if you were around for something, reach out. We have that information. And then the most important announcement to make is that Summer Institute's coming up. We're just less than 2 months away, which is just unbelievable. Like, we have been busy planning, the planning committee's been awesome. And I want to just share a couple of things. There were a few, this is from the MPC. So just want to share that it is time to be booking travel. So this week, you should be getting 3 email confirmations for Summer Institute. And so one you should have gotten already, and that's your hotel confirmation information. And so that came from Amanda's email, so you should have already gotten that. Tomorrow, you will be getting an email from our Hopkins travel with information from the HPRS email address with information for the Hopkins travel agent. So there will book your travel for you. You're not paying out of pocket. Like, we have people who are going to book for you, but we need you to engage with that email and respond. Later this week, we're sending out, we use an app called Guidebook, where everyth's posted, where we'll have information about the Summer Institute, where you can connect with each other. Again, so action will be required there if you choose to engage with the app. I know that I want to acknowledge that not everybody has smartphones or an app. Like, you might say, Keisha, are you serious? No, yes, there are people I know in our community who don't all have smartphones. And so if you decide that, or this technology doesn't work, you will absolutely be able to log on to the website and you'll be able to see what we're looking at on the app. If by next Monday, April 29th, you have not gotten these 3 emails, please reach out to HPRS Box, because everybody should have gotten a message. If you're missing one, please look in your spam folder, but want to just remind everybody that you should have gotten the hotel confirmation and that you'll be getting an email tomorrow from the travel agent. And then you'll be getting an email later this week on the 26th with Guidebook login invites, where you'll start to see information about Summer Institute. So any questions about that, reach out to me or reach out to the HPRS Box. So that's my main announcement for today. Does anybody have a question about any of those emails that you should be getting? I don't see any hands, and I don't see anything in the chat. Okay, great. So before I turn it over to our speaker, we started our spring term really focusing on policy. We integrated our values, and then we really focus on different aspects of policy. And today I'm really excited and just thrilled to welcome Corey Jacinto, who is certainly part of HPRS, is the TA for this class, and is also an amazing colleague and somebody who I respect and admire and is doing great work. And I'm so excited that Corey is going to share some of his wisdom with you all today. So I'll turn it over to Corey in a second. And then, as a reminder, our last session together is on the 24th of May. Your brief problem statements due. If you need an extension, reach out to me. There's an example on the portal with some instructions about what I'm asking for. It's very short, so just to get you all going in terms of thinking about the problem you want to focus on. We'll pick it back up at the Summer Institute, but between when you submit and the SI, I will read all of those and provide some comments. So if you have questions, reach out to me. I'll be sure to send an email maybe tomorrow, just reminding people of the problem statement and what we're looking for. So again, just thrilled. I'm going to stop sharing and I'm going to turn it to my colleague Corey, who's going to be presenting today. So Corey, the floor is yours.
Great, thank you. This is my second time doing this lecture, and super blessed. Is last time doing it as an active scholar. Hopefully I'll be back next year as a alum, right? It's a blessing. I'm just, it's fantastic to be in front of y'all, and just can't wait to see y'all in a couple months here. In Baltimore. And yes, I'm a little tall, and just don't point that out. That's usually the first thing that people say. I'm like, oh, what did you learn about the lecture? I'm like, oh, you're just tall. Yeah, super blessed. So let me go ahead and share my slides here. Cool. Can you all see it? Okay, cool. So yeah, I'm going to be talking about economics and health policy, public health policy, and how those two really intertwine, right? So just to think about some learning objectives, and then honestly, like interject at any point that, you know, if you have a question or anything. I think it's important to preface it a little bit, like I've walked in your shoes, I've been there, and court 7, I've been blessed to learn about court 6 and have a pretty intimate, relatively intimate relationship with a lot of folks. And so it's just a blessing to know you guys and know just the work that you guys are pushing forward. And so I'm just really happy to be a part of it. Like it's really a blessing. So but today there's 3 learning objectives, right? So the first one is I really want you guys to be a little bit more adept at understanding how policy is constructed and analyzed under traditional economic theory paradigms, right? I know you guys have varying backgrounds in terms of economic exposure, right? And so some of you guys have taken intro courses, some of you all have taken in-depth courses, right? And so just I try to really acknowledge that. Secondly, I just want you all to gain a greater knowledge of how economic evaluation has and can impact health policy and public health decision-making, the public health decision-making process. You get stuck in your research, and I think economics is such an important part. It augments what you could do, right, in so many different ways. And we'll learn a little bit more about that, right? And then lastly, I want you to really just gain a greater understanding of how behavioral economics can help to create more astute policies and interventions. And I'm going to lead a little bit on some of the work I've done previously to kind of shed light upon that. And so, yeah, you'll see. But so economics, right? I have my PhD, my bachelor's was in economics. I have a MPH with a concentration in health economics. So I mean, we every decision we make is goes back to economics in a way, right? And it's really the study of allocation of scarce resources, right? We have limited time, we have limited money, we have limited resources in general, right? And how do we allocate those, right? And so classical economic theory conveniently but wrongly assumes that individuals and firms are rational actors seeking to maximize their own well-being, right? So all these paradigms we talk about in classical economic theory, we assume they have full information, right? And they're always trying to maximize their utility, right? What that means, right? Easier said than done. And we assume that under like ideal conditions, laissez-faire markets, right? Leave the markets to what they are. They always lead to efficient equilibriums, right? Which means that efficient allocation of scarce resources. But that's not true, right? Ideal conditions are rarely met. So we have to contend with these market failures, right? This notion that markets just equilibrize in a way that's fair and equitable is not true, right? Especially when you could alter markets, right? So market failures, or that's huge. It's like fundamental to economic theory. And we think about these things all the time, right? Think about imperfect information and informational asymmetries, right? I mean, as PhD students, you guys have all this information thrown at you, right? And you have to distill all this stuff, right? And I will say, relatively, I think we're in a position where we have a lot of information and we're able to utilize that information and make decisions. But even with that position, like it's still hard to make choices, right? We're not rational actors, right? So we're constantly dealing with negative and positive externalities, right? In these markets. And we'll get a little bit more into that, right? We're also dealing with time inconsistencies, right? And that just means, so think about the choices you made. I love to bring this to light. It says go on this PhD path, right? And you're all in your different disciplines and whatnot. And this an internal choice to go down this path, right? For this payout down the line, right? And we think about discount factors and how people make choices considering the payout down the line, 2, 5, 10 years down the line, right? And it's and so yeah, and so we'll touch more upon that, right? And then my favorite, excessive market power, right? We deal with these markets and we think they're laissez-faire, but people control markets, right? The systems we're in, the actors that we deal with, right? They exert market power, right? And we'll talk about monopolies and things of that nature. That being said, right, there's a clear economic rationale for governments to intervene via the use of laws, regulations, and other policies, right? And the hope is that we really minimize these inefficiencies that we see in these markets, right? And ideally, improve public health, right? So I think so having been in your shoes, right, and being cohort 4, which is thus far the best cohort, even though every cohort out there is like super impressive. Like you guys just up the game, after every cohort, right? But thinking about let's talk about policy levers to mitigate market failures, right? These market failures that I alluded to earlier. This is why we're here. This is the program, and I think I'm so blessed to have this lecture because I've been in your shoes, and we've had great lecturers, absolutely. But I always, when I created this lecture, I just go back to like the research, right, and how we actually can use law and policy, right, to alter our conditions, right, for the sake of the betterment of our public health. And so law and policy can facilitate many, and we've had lectures before, right? But law and policy can really facilitate public health interventions, right? In multiple ways. And these are some examples: safe housing, healthy food, access to education and employment opportunities, reducing environmental pollution, creating health-promoting built environments, reinforcing healthy social norms and practices, right? All these things can be done through law and policy. So I just want to highlight a couple things, right? And tools that we as researchers, as policy influencers, right? There's some fundamental public health law and policy tools that I think we have in our arsenal, right? That we could really leverage, and that you'll learn to leverage as you go forward. And a couple of these things are, direct regulation, deregulation, taxation, spending, budgetary allocation, tort liability, and all these things are used to alter the world we live in, right? Whether that's the built environment, the informational environment, and really, this speaks to my soul, is the socioeconomic determinants of health, right? The things that I think really determine health outcomes, population health outcomes. So I'm just going to go through a couple of these. So direct regulation, right? This is something that we could. It's more straightforward and direct, right? And it's command and control style regulation. Some of these examples, right, include mandated signage to remind employees to wash their hands, sneeze guards in self-serve food areas, nutrition labeling on packaged foods and menus. These are all examples of direct regulation, right? What speaks to me though is nudge style approaches. I'm gonna you see in the next slide, but these are things that really actions, policies, interventions that really attempt to influence individuals' choices for their own benefit, while still enabling the autonomy of an individual, right? And the choices they make about their own health. So there's a couple of examples here. Opt-out versus opt-in approaches to sex education in schools. Even changing the way items are listed on a menu or the way foods are displayed in a grocery store. So everyone shops at a grocery store, right? Whatever, Trader Joe's, Costco, whatever. But next time you go in, just be a little mindful of where things are set up and why that is, right? And why they might push certain foods on you, right? And just be mindful of the layout, right? And so these are just nudge examples. And so I'm gonna this book, Nudge, I think is very seminal to the way I think about the world, the way I think about policymaking, the way I think about interventions. right? And I'm not gonna harp on it too much, but this is like a seminal book. I've like pushed it on the book club and it was rejected, but that's okay. Maybe next time, right? No, but seriously, like this book is when you think about these real world examples of how we make decisions and how we just, I think, put people in positions to make better decisions that promote their health, right? This book really touches upon that, and so it's incredible. So I highly recommend it. So going on to deregulation, right? Thinking about right, deregulation can remove legal barriers to public health intervention. So some examples here, changing zoning laws to allow tiny homes, tiny communities to operate, right? And I think, here in Denver, I'll just put a plug in for be very mindful and like actually put as much as you can into these policy memos. And that's going to translate into other deliverables, i.e. Really deliverables that I think are translatable. And I think I'll just speak to this course and I wrote a op-ed on tiny homes, and I wrote it a couple of years ago, and lo and behold, there's tiny homes operating here in Denver, Colorado. And this is interesting how you're just one piece of the puzzle, right? And like that, I think that piece, I never would have wrote that piece if not for this course, right? And I think I was able to influence policy in ways that I didn't even imagine, right? And we have tiny homes operating. Now, we're not going to get into like how they're failing in many ways, but it's just translatable. And so thinking about like how just think outside the box, right? And so also suspending regulations to allow public or to allow healthcare providers to practice outside their usual scope. And so what comes to mind here is safe injection facilities, for example, right? There's a lot of underground safe injection facilities, right? There's a lot of work being done. And so just thinking about how you could operate outside the law. It's, we have these regulations and these restrictions, and there's people just making moves because they see a need for it. When people are dying from fentanyl, they're these SIFs are popping up because there's a need for it, and they're doing it regardless of the legality, right? And they're putting it all on the line. It's incredible. So some of these are inextricably tied to the principle of harm reduction, right? So I just talked about safe injection facilities, needle exchange programs, naloxone access, and these are all things that I think no matter where you're at, I know we're all across the country, different cities and whatnot, but these are things that are happening right now, right? These are things that are saving lives right now, and so these are things that we got to keep pushing, right? And it's under this parameter, this umbrella of deregulation, right? And so it's important for protecting the health of groups who are vulnerable to these sanctions, right? Think about the people who use naloxone, who use needle exchange programs, who use safe consumption sites, right? These are very vulnerable people, people who have SUDs, people who are undocumented, that means, these are sex workers, right? And so, that's really, what falls under deregulation. So when I say deregulation, think about how you could work outside the box, right? Work outside these laws that have been set, right? And change laws, right? Taxation and subsidies. Honestly, this is one of the I think this is one of the biggest levers, because money talks, right? Money talks. And so with taxation and subsidies, you're able, you hit people's pockets, right? And so I know there's a graphic here, right? And there's you think about a 10% increase in the taxation of tobacco, right? Tobacco products, right? And see what that leads to in terms of the prevalence of smoking, particularly in people who are underage, right? And 5 to 15%, right, of decrease in smoking of people who are underage, 3 to 7% among adults, and that's only that that difference. So there's a difference there, right, and it's a little higher among people who are underage, right. And that's because habits are formed, and adults are a little bit harder to nudge, right, a little bit harder to really hit their pockets. So examples of tax burdens are cigarettes, alcohol, firearms, sugar taxes, disposable grocery bags. So I don't know where y'all live. I know here, they impose a 10% tax, which I gladly pay for, right? If I forget my reusable bags and I want to go grocery shopping, and there's a reason for that, right? And these are all things that really incentivize health promoting activities, right? These are things that, like, taxes and subsidies. Subsidies, for example, I think the prime example, particularly in health policy, is subsidies for vaccines, right? People who want to get vaccinated or who wouldn't get vaccinated otherwise, as I should say, right? And make that zero cost at the point of transaction, right? And so taxes and subsidies really help to internalize the true cost of economic decisions and behaviors, right? We don't, people who, for example, people who smoke, right, and the secondhand smoke and they're puffing, whatever, do your thing, right? But I think they don't think about the secondhand smoke and third-hand smoke, right, that we've learned about, right? They don't internalize those costs, right? So they keep smoking because it's that true cost to them and society is not internalized, right? And so I think taxes really help internalize those costs. And so it's incredibly important. And I think, like I said, taxes and subsidies are probably the biggest lever that we have in our health policy toolkit, so to speak, to really move the needle. Taxes talk, they just do. And so we'll get more into that. And so another thing is spending and budgetary allocation, right? So as governments, right, they get taxes, right, and they're with the tax revenue, they support a wide array of public health services, right, including a public health infrastructure, which includes a well-trained workforce, electronic information and communication systems, rapid disease surveillance, response capability, which I think is all, as we've gotten out of the pandemic, thank God. But we've seen that in action, right, with COVID-19, and we've seen that at the forefront. And so governments can also impose health-related conditions on recipients of funds. And I think that's important, especially in our sphere that we talk about, right? We think about vulnerable populations and what that means. And so we think about a lot of safety net programs, including Medicaid, SNAP, for example. I love Keisha's SNAP story about how she presented to a bunch of folks at Capitol Hill, and just the misconceptions about what SNAP is really, what that funding really goes to, right? And there's a lot of misconceptions around that, and it's unfortunate. Education and housing programs, all these things are incredibly important in terms of social safety net programs. And governments, again, have this ability to allocate funds to these and prioritize these. So it's incredibly important who we vote into office, right? Who we elect as leaders. And then there's tort liability, right? Which is, I don't know if there's any lawyers out there, right? But this is really where they come into play, right? And so attorneys, public health authorities, private citizens can seek redress for many public health harms and through civil litigation. And I think in our last lecture, it was brought up at how Big Pharma, right, is having to pay not nearly enough, to be honest, but they're having to pay, right? They're having to pay out big funds because of their role in the opioid epidemic, right? To push on the doctors, to push on these pills, right? And I always, it's always interesting to me because some of my background is in substance use disorder, and it's so interesting to me that, and it's great, it's fantastic that our SUD systems are being bolstered. But I always say, like, where was this in the 80s, right? When was this when, they were destroying Black communities and infiltrating our communities of crack and doing all that? Where was this? And so the public health epidemic as is in terms of the opioids, and it's evolved, and I'll touch on that a little bit later. It's great that we have funding now. It's fantastic, absolutely. But you got to think about who is it affecting, why they're putting money into it now, right? And why that looks good now. Back in the 80s, 90s, nobody cared about it. Nobody cared about it because it was destroying a certain demographic. But I think this epidemic that we have now transcends social, economic, pretty much every demographic line, right? And so we're seeing that in terms of the policy sphere, right? So anyway, litigation can really raise awareness about health and safety, right? Again, about I'll draw upon the public health epidemic of opioids and how that's transpired and how we've gotten to this situation now where people are seeing fentanyl. It's wild, right? It's if you have an ear to the floor, it's really wild how, and I'll talk about it a little bit later in one of the models I've built or have been a part of, and it's always changing, and so it's super important that we raise awareness about the health and safety risk, and make information available to the public, right? Because that leads to an increase in political will to strengthen regulatory regimes that are important, that are going to actually serve the people. So again, some examples of these, right, are environmental damage, air and water contamination, exposure to toxic substances, lead paint. I think this is before all our times, but we literally were driving around cars that had lead in the gas, right? And we're pumping this lead into the air, right? And thinking about the health ramifications of that, right? And we've since evolved, but we've learned, right? Doesn't mean there's not other things, pesticides, asbestos, right? Things that I think disproportionately affect certain communities. And just thinking about who they affect and the prioritization on the policy agenda, right? Badly designed or defective products, children's toys, household goods. I think it was brought up last lecture, I think, about the Pinto, right? Of cars, like, this is a real thing, like it's a real thing, right? And so these are things I just gotta notice about a recall, right, on old Toyota Corolla. And these things are very much real, right? And things that we have to think about and things that affect people. And then marketing and distribution practices of hazardous products, tobacco, marijuana, firearms, prescription opioids. I think we're as a nation, we're about half the states have legalized recreational marijuana, right? And I think it's just a matter of time, hopefully, that we get to a point where it's legal on a federal level, right? But that being said, there's regulations and laws around how we market that, where we place these dispensaries, right? That's super important, right? We don't want these dispensaries next to schools. We don't want these dispensaries next to certain vulnerable populations, right? We don't. And so thinking about how we do that is extremely interesting. So I think one of the things we have, these policy levers, right, can help us also the built environment. So much of what we do and the spaces that we live in, right, it's built, like we build this. I think we often forget about that. Like we build these, we build these structures, we build where we live, we build these spaces that we interact, right, where we work, play, eat, live. And so law and policy can really be used to reduce injury, infectious disease, and toxic exposures, right? And so thinking about workplace safety, I know there's a couple of folks in the group that think about, or a lot of their work is, some of their work is concentrated on occupational safety, right? So workplace safety, traffic zones, fire codes, sanitation, zoning, housing codes. So for example, again, Denver is it's been interesting to be here because we're dealing with a homelessness crisis, as many parts of the country are, right? And how we and it's been a very high on the priority agenda of the mayor here and other legislators, right? And there's no simple solution. It's not easy. Housing is probably honestly one of the most complex things that we tackle as policymakers, as people who are focused on equity, right? And this fundamental, I think, right that we have to housing, and how it's so commodified. And like, I could take a 10-minute drive down the way, and we have these tiny homes, and are they really adequate for the population that they're intended to serve, right? Those are questions that I think we have to be thinking about constantly. And I don't know if they are. I think those are that answers for greater minds than mine. But that being said, it starts at local governments, right? We could use our zoning, licensing, and permitting authority to encourage healthier choices, right? And so this includes like reducing dead safe tobacco, alcohol, or fast food retailers, right? And increasing access to grocery stores, right? So we think about food deserts, we think about food swamps, right? And thinking about that access. It's in many ways an issue of policy, right? Where we allow these things to pop up. Like, tell me why we could go to certain parts of any city, right? And there's a lot more tobacco stores, there's a lot more alcohol stores, right? We won't, we'll say it's correlation, right? But think about the people who live in these communities where these things are, right? And why is that? Right? And think about the political empowerment or lack of empowerment that certain folks have, right? And why these stores pop up. But it's also about increasing recreational space and promoting forms of transportation, right? So bike lanes, more walkability. And I think certain cities in America do this better than others. There's you think about other cities in like Europe and whatnot, they just promote that a little bit more, right? And so just thinking about that recreational space, the access to green spaces that certain people have and certain people don't have, and why is that, right? And what that means in terms of healthy outcomes, right? Being able to like walk outside in comfort, right? And enjoy a green space, being able to fly a kite with your daughter or son, right? That's not guaranteed to anybody, unfortunately, right? So those are the ways that we could alter the built environment, right? So thinking about the informational environment, information is like, so, I mean, I'm talking a whole slew of PhD students, right? Information, well, the more we know, the more we don't know, right? And so, we're inundated with information at times, right? But I think we're in a position where we're able to really filter a lot of that, right? And we need to, right? And so governments can alter the information environment, and they do, right, to encourage people to make healthier choices. And this includes, health communication campaigns, limiting harmful or misleading information for potentially harmful products, mandating warning labels. I think about, you go to fast food places, right? And how it's been a change. If you went to a fast food place, 10 years ago, you don't know the caloric value. You don't know that stuff. Now, look them, you order anything, that stuff's fairly readily available, right? Like you're able to like, hey, this is what I'm consuming. I'm going to order this. These are the calories that I'm consuming, right? And so I think, we live in an age where there's more information, which is good, right? But we still have to filter through that, right? And so, these things can be controversial, as economic and constitutional interests may be at stake, right? So, health communication about smoking, right? Food and beverage consumption, gun ownership and safe storage, family planning. So all these things, there's a lot of information, like there's a lot, right? And there's a lot of disinformation, unfortunately, or misinformation, right? I think about smoking, for example, and we've come a long way, thank God. And I think the evidence was so irrefutable, right? Like smoking causes cancer, right? And that was so irrefutable. And people came to learn this and implemented it in policy, right? Like we, you know, we don't, we don't, you can't just smoke anywhere anymore, right? People are mindful of that, right? There's policies on, not only on like a state, local level, but just like on a more parochial institutional level, right? People don't, they just ban it, right? So I think all these things are important, you know, all four of these areas. And these are just four areas that they're not, they don't encompass everything, right? But I think these are four that are pretty prominent when we think about health communications, right? Family planning, there's such a division in family planning. There's literally places right now where unfortunately people are afraid to go, you know, women are afraid to go make decisions about their bodies and their family planning because they live in a certain state, right? They live in a certain political environment. And it's extremely unfortunate and in some ways asinine, right? So we'll get more into that a little bit later. But these are all things that thinking about the information environment and how we consume, how we receive information, how we alter information, right? How we interpret information, extremely important. So, and then talking about the socioeconomic determinants of health, right? This is really up my purview in terms of my research interests, right? And so taxation and spending can really be used to redistribute resources and reduce inequality. And this can come in many different ways, right? Regulation, as I referred to earlier, tort litigation can also have these distributional effects, right? But many public health advocates believe a reduction of health disparities is like, that's what we believe. I think everybody in this room, right, will stand by that, right? We believe that mitigating health disparities in any shape and form is a social imperative. That's why we're in this room. That's why they built HPRS. That's what we do at the end of the day, right? That's what we're about ultimately. And so, but that being said, there's this notion that like economic conservatives believe like, just leave the free market alone and it's all gonna work out, right? It's all gonna work out. It's all gonna be good, right? It doesn't, that's not, I mean, in theory, right? In theory that it would, but that's not how it plays out in real life, right? And so people wield influence on the free market, right? And so so some of these things, right, in terms of like how we alter the socioeconomic in terms of health, there's many different ways we could do that. So there's some examples here: increasing access to education, employment, and housing opportunities. Easier said than done, right? Easier said than done. I think, you know, we have programs like this. We have a multitude of different things to address it, and it's complicated, right? Thinking about raising the minimum wage. I know cohort 6, I you know, had some intimate conversations about universal basic income, right? And that's been interesting. That's something that's interesting to me because it's not that simple. And I think when we talk about economics, right? And you know, you increase the universal basic, you know, so everyone has a universal basic income, right? What does that mean though, right? What that means is probably, honestly, you're just raising the price floor, right? Everything just becomes more expensive, right? So like you give people X amount of money, then they're going to be charged X amount more for their basic necessities, right? So not going to harp on universal basic income, but I think you know, raising the minimum wage is not the exact same thing. It's something different, right? And think about folks who you know, have certain occupations, right? And how that plays out in terms of their ability to afford the basic necessities, right? Not only that, not only the basic necessities, but to afford a better life, right? And part of that is increasing the earned income tax credit, right? And these are all levers, right? These are all things, these are all policy levers, right? These are people making decisions in terms of raising the minimum wage, right? What's the minimum wage in your state? right? What's the minimum wage on a federal level, right? These are things that impact economies on a whole. And so also increasing the earned income tax credit, right? And what that means can be it's a policy lever. That's, I think, very important. And so all these things I know kind of like coalesce all these things, right? So we have laws, and it's kind of built upon the last lecture we have, right? But there's certain levers, right? We have taxation, price controls, market power, right? Whether that's antitrust. For example, I don't know if anyone's really following this, right? But Kroger is basically trying to buy every grocery store in America, right? And they've had to divest because they've bought Safeway. So they're selling off Safeway so they can make this merger, right? So these are things that I think affect people that we're not always privy to, right? And so thinking about other market power dynamics of barriers to entry and exit, which we'll talk about, and more a parochial example in terms of a higher labor market, but licensure, patent protection, information, labeling, warnings, campaigns, all these things, all these levers, right? On the left side are really meant to influence the price, right? The internal price of things, right? Whether that's monetary, time, health costs, especially legal costs, right? All these things lead to or influence consumer and producer choices and behaviors, right? And what we decide, right, can lead to negative externalities or positive externalities or ideal market. So something I think about it's always kind of stuck with me is the price of a burger. So you go buy a burger, right? We don't think about, like, you go pay on wherever you're at, right? Let's just say $8 for a burger, right? Is that really the cost of a burger, right? We don't internalize, but we don't have to, because the market doesn't make us internalize the true cost of a burger. We don't think about the climate cost that comes with raising that cow, right? Or transporting that beef to the market, right? Moreover, we don't think about how that plays into, here in America, we have a obesity epidemic, right? We don't think about how that plays into that and how we internalize those costs, right? And so I think it's very important how we think about our actions, our behaviors, our choices lead to no market's perfect. So, you see ideal market here, like that's ideal, is it not? We don't get there. So we're often in this negative externality or positive externality space, right? Where whatever we consume, right, is either, it could be overconsumption or underconsumption. So I think about vaccines, for example, and the COVID-19, right? And thinking about how it was made free for a reason, right? Because there was an underconsumption, right? And there's a positive externality. I'm sure most of you have heard of herd immunity, right? And this thing that comes with protecting our people. Like, I was absolutely skeptical of getting a COVID-19 vaccine. Like, is the research really there? Like, what is this going to, like, and a lot of hesitation. I think for me personally, I just put faith in the fact that I think people did the research, and also knowing that, like, it wasn't this, like, they were prepared for this, right? Like, COVID-19 was a strain of a certain type of disease, right? That they've been studying. And so thinking about when this epidemic hit, like, I have a 90-some-year-old grandmother, right? I have people who are more vulnerable than myself, right? And what that means when I interact with them. So any negative effects that I would get from a vaccine, it doesn't matter, because of the positive externalities, right, of herd immunity, right, of the health benefits of protecting my community. And we'll talk a little more about that later. But all these things, right, influence population health outcomes, which is, I think, something that we're all focused on. And so just to turn the page a little bit, so I was part of forcing to be a part of this, the showcase study. And so I think this really ties into health economic paradigms and how we think about theory, right? And so I know state health officials, they're super important. Well, they lead the state health departments. They're like, if you think about population health outcomes, they're top three in terms of determinants, in terms of people who influence those state health outcomes, right? And so it's a highly skilled labor market that has huge implications. Like I said, they lead our health departments, and so state health departments, and there's different structures and whatnot, but for the most part, they're in charge of a lot of different things, and you know, they're delineated right here, right? But mainly disease surveillance, epidemiology, data collection, healthcare services, preparedness, and response to public health emergencies, population-based primary preventions, regulation of healthcare providers and other licensed professionals, environmental health, all these different things, right? So I think this study was super interesting because there's actually codified laws that require these state health officials to possess certain educational credentials, and mainly this is they have to have a MD, right? They have to go through med school, have an MD, and I think it's a little archaic, to be honest, because think about folks who, you know, so you're telling me that, you know, someone who's brand new, they have an MD, they come in the game and just know how to run a state health department, but better than relatively to somebody who's 30 years, a 30-year veteran, right? Who's been in different sub departments of the state health department, just knows it in and out. And you're telling me the MD is more qualified. I think a little problematic, right? So what the study found is that show tenure, state health department tenure is often subject to turnover in political office, right? And that's because in 35 states, and these numbers may be a little bit probably need to update this a little bit, but for the most part, they're still there. 35 states, shows are appointed by a governor, right? So you think about, you know, we have these elections, the show comes in, and think about the turnover and what that means for a state health department, right? 35 states, new governor comes in, they want to run the show, they're putting their people in place, cool, right? But what does that mean from a public or population health standpoint, right? It could be a little problematic when you have that turnover. In 12 states, shows are appointed by the secretary of umbrella health related agency. So a little still political, absolutely, because those secretaries are often appointed by governor. And in 4 states, they're appointed by a board of health. And we'll see, right, here in the graphic, look at the tenure difference, like double, right? Look at that. And I think there's something to be said about staying power. You know, if you're appointed by a board of health, on average 8.5 years compared to just under 4. So yeah, over, you know, double, right? And so you know, probably you could pick out your states here, right? But we see an array of the show appointing authority here, right? And we see, you know, where these states have where the shows are appointed by a board of health or a governor, right? And so yeah, so I mean, look at your state and just be mindful of you know, who's appointing your, you know, state health official. So anyway, that's to say, when we think of when it's related back to economic theory, right, and economic these paradigms, right, and so it's really what these restrictions are, they really amount to a barrier into entry into a highly skilled labor market, right? Think about the folks who can run state health departments, and the fact that we have these educational requirements, I think, are restricting absolutely qualified people from attaining these roles, right? And it's the educational requirements as well as a function of political turnover, right? And like I said, a new governor comes in and you know, they appoint somebody else, right? And so ultimately, from a policy standpoint, right? I want y'all to think about this from a policy standpoint and what can be done, right? And this is all regulations, right? This is something that can be changed on a policy law level, right? And this entails changing laws around show requirements. Why do we, I get at one point in time, it's probably wise to have an MD requirement, but I think we're past that, right? I think, it doesn't just because you're MD doesn't mean you're qualified to run a state health department, right? Like by any means, right? And again, because of it's limiting the entry to this highly skilled labor market. When there's folks that are more than qualified, have been working with the state health department, know its in and outs, have made those connections, who are probably honestly more effective and efficient than some new gun coming in because they were appointed by a governor. They donated a lot of money. So like, oh, you're the show now, right? Like, what is that? And so I think we need to change the laws around show requirements and change the appointing authority, right? Like I alluded to, when we have a board of health, when it's not just the governor coming in and making those decisions, when it's actually a board of people appointing that authority, we see the change in tenure. We see twofold, right? So I think that's critically important.
Yeah. Corey, can I just make one comment on this? This has been really, really great. One of the things I wanted to just lift up to get to tie to an earlier point you made, which is around COVID. I think in terms of, as we saw, there was this really mass exodus of public health leaders during COVID, and many of the people who were fired or were forced to resign were those positions that were politically appointed, right? Just to get to your point about what do we know when sort of those political forces are impacting, how people are appointed to those positions, and how some of them are so tied to the politics and policy process. I just wanted to name that. That's been, I talked to a health officer recently who was fired because of decisions they made during COVID, right? And so thinking about just how political it was, that they were saying things in support of evidence and science and not the political leader who had appointed them to that position.
Right. No, thank you for uplifting that. Absolutely. I know some people I just leave in the chat. Some people have to hop up. That's good. That's cool. Kind of next, turn gears a little bit. What is economic evaluation, right? And so this is something that I, as a economist, right, or have that background in economy, right, economic evaluation. I think this is one of the most powerful tools I think we have at our disposal. It's not a perfect science by any means, right? But it's this systematic appraisal of costs and benefits of projects, right? And really relating these to alternatives, program and policy alternatives, right? And it's really, as Thomas Frieden said, it's really critical to understand the full range of available evidence-based strategies and the size and characteristics of the population to be reached, and the population impact of each intervention and the estimated costs, right? We live in a world, right? There's scarce economic resources, right? We have to make decisions under this rule of scarcity, right? And so I think that's where the power lies in economic evaluation. It's a tool to evaluate these alternatives relative to each other. And it's not a perfect science by any means, but and it's something that we have at our disposal. And I know folks that would a wide array of backgrounds, right? But thinking about, I think this slide's critically important because, thinking about your research that y'all do and you're engaged in, thinking about how you could attach that, because numbers speak, right? Money talks, how you could attach that economic evaluation to a project you're on, right? To something that you're already engaged in. And so there's a number of different tools that we have that economists use to evaluate different things, right? So, and as you see them here, right, there's the cost of illness analysis, program cost analysis, right? And these things are critical in public health because public health decision makers often use these things at various levels, right? And this is kind of like the baseline to fuller or more, I should say, more robust economic evaluation. And there's really three that stand out. There's cost benefit analysis. And so that entails, this comparison of different programs with different health outcomes or different outcomes, right? And there's this benefit cost ratio, and I'll speak a little bit more on that in terms of how we quantify benefits, right? I think costs are a little bit easier, but how we quantify benefits is a more difficult practice. But that being said, I think there's also cost effectiveness analysis, right? And so I think this is important because you're able to compare interventions with the same outcomes. So the example here is cervical cancer interventions, right? So looking at various different programs, right? And comparing how effective that's going to be on a cost level per like cases averted, right? So two different programs, how many cases of cervical cancer are averted for program 1 versus program 2, and then what are the costs of those programs, right? And there's cost utility analysis, and this compares interventions with different health outcomes, and so this is a powerful tool, especially for us, because we're able to obviously compare different states, right? So the example here is cervical cancer versus Alzheimer's disease, right? And so the main measure here is cost utility ratio, right? How many, and we'll get into qualities, you know, how much per quality saved, right? How much per quality adjusted life saved are these interventions affecting, right? And this could be done at different levels, you know, agency level, a federal level, state level, local level, and we'll get into a little bit more on how that's actually done. So I just want to speak a little bit about I know, you know, when I constructed, you know, this lecture, it's at least I've kind of, you know, walked in your steps, and so I wanted to bring it back to their research, and so I was fortunate to be able to be a part of the Win-Win project, which is housed at UCLA, but it's an incredible project because they work with like real actors, real departments that affect change, and so one of the projects we worked with the LA County Department of Public Health, Substance Use Prevention and Control. And so with this one, we modeled 3 different opioid interventions, right? Medication assisted treatment, recovery bridge housing, and fentanyl test strips. And so I guess I led the fentanyl test strips, which was very didactic and super informative for me, because it's at the time, now it's evolved now, and it's you know, it's interesting how it's evolved, but at the time, you know, fentanyl was a burgeoning epidemic, right? And so you had there wasn't a lot of research in terms of being able to put things in these models, right? And so a lot of assumptions, you know, had to be made, and that's how models are built, right? On these assumptions, right? And you test these assumptions, and you know, that's what it is, right? Now, if I was to make this model again, I'd probably do it a little differently, knowing that there's a lot more fentanyl seeking folks out there, right? But these models, right, were really intended to help inform LA County in terms of how to mitigate opioid use related outcomes, right? So like I said, I headed the fentanyl test strip program at the time. There wasn't a lot of research out there, and so there's a little bit, but it was fairly novel, and so the thought was, with these test strips, they'd be able to test the presence of fentanyl in the drug supply, and so again, the oldest studies were from 2017. They've since been updated, and so again, this model would probably be a little bit different, I would imagine, if we made it now, but really the questions were, do opioid users use fentanyl drug strips if they're provided? The research showed yes. Do opioid users alter drug behavior due to positive tests? Research showed yes. And then, do opioid users experience an increased perceived safety when using these test strips? Answer is yes. All things that are good in terms of the model, right? And so thinking about the model logic for FTS, right? Participation in these, right, will you give people federal test strips, right? It's gonna lead to protective health behavior, in that people will use smaller amount of drugs, or they will throw tainted drugs away, right? And then this leads to a decrease in overdose risk, which leads to a decrease in ED visits, in theory, ED visits, hospitalizations, and fentanyl related mortalities, right? So this is super interesting because again, we all south for LA County, right? And there was approximately 120,000 folks who could be enrolled. It says enrolled here, but could be affected by this intervention. And at the time, right, 69% of FTS users are non-fentanyl seeking. That number has probably changed a little bit, right? But with this model, 52,000 adults receive some benefits from the treatment. And then 46%, we assume 46% intervention penetrance, which just means you give these folks, this population, the eligible population, and about 46%, right, will be exposed to FTS strips, right? And then 95% are willing to use. And there's an array of different estimates, right? In this model, we used 95% as that number, but as you can see, it's 42 to 90%, right? So a wide array of different, that's huge. That's a huge, kind of a huge interval, right? 42% to 95, really, actually a huge, right? So that being said, this is super interesting, because what we found, right, and we tested, 2 other interventions, but this was so interesting because I think when I made the model, random numbers, I guess it didn't hit right away, and I had to like digest it a little bit, and it made sense, right? So if you look at these numbers, 27% fewer ED visits, right? 8 fewer hospitalizations, right? And 74 fewer deaths. I think that's where the value of this intervention comes into play, right? Because you think about fentanyl and fentanyl users, it makes sense because if you OD on fentanyl, you're not going to the emergency department. You're not being hospitalized, right? You're dying, right? It's that powerful a drug. And so I think the value of this intervention, right, is really manifested in the fewer deaths averted. And so, yeah, 74, which you put it in numbers, right? And this is where cost effective analysis comes in, right? And thinking about mortalities averted. If you look at 74% fewer and assuming a total program cost of 6.3 million, that comes out to about $85,000 per mortality averted. Or if you use a kind of a lower baseline of 4.7 total program cost, about $58,000 per mortality averted, right? And so these are numbers that I think the folks at LA County had to digest and also decide what's worth it, right? Is $85,000 per mortality averted worth it? That's the question they had to answer. Fortunately, not me. And so that leads to like, how do we value a life, right? And this is one of the most challenging aspects of economic evaluation. And we're going to get an exercise here. Is how do we value a life, right? How do we value the quality of life in a disease state? And that's extremely challenging because often, if you've never had a disease, you never lived the disease, how do you know the quality of life in that state, right? It's hard to ascertain what that is, right? So we're gonna play a quick game that involves a hypothetical Frogger. And so I think I need you, Keisha, or I could probably do it myself.
What do you need me to do, Corey?
We just need can we get a poll up there? This last question. Just we could just maybe copy and paste that, and yes or no, that'd be great.
I can't see the questions. Oh, that one right there. Sorry, it was covered. Sorry. I can't. It's not letting me copy it, so I have to type it. So just give me a second.
Yeah, take your time. So I will set this up while she's graciously, putting this in the poll. So folks, you're given this opportunity to cross. I'm sure most of you hopefully have played Frogger, right? Familiar at least. So you're given this opportunity to cross a 5-lane highway to retrieve this briefcase, which has $100,000 in it, right? It's, a lot of money. And you're able to get this, right? tax-free, it's yours if you go across this highway. Now, you ascertain that, it's about a 1 in 100 chance that if you cross this highway, you're gonna get hit by a car, you're gonna die, right? So the question is, do you cross this highway for a windfall of $100,000, knowing that there's a 1 in 100 chance
Mhm.
of that?
Corey, do you only want yes and no, or do you want any other choices?
Let's just do yes and no. Yeah,
Okay.
yes and no. Yep, thank you.
All right, it's see, oh, okay. Let's see, do you want me to launch it now?
Yes, let's please.
Can you see it?
I can, yes.
Okay, awesome. We have 90% participated, which got a couple more.
I was looking at the time, we're running out of time, so we're
One
gonna.
more, all right, I could stop it. One more person.
We're good, they're good.
Oh, we're good, okay.
But we know, let me write this down. We said yes. 5 out of 10%, no, 74%. Okay, cool. Not really the time. Okay, so now that's scenario 1, right? And then let's do scenario 2. I want you to answer this. Can we launch
Let
another
me
poll?
end do you want me to show the answers or just?
Yeah, show the answers. That's fine.
Okay,
Yes.
so let me end the poll and share results. Here we go. So 74% said no.
Okay, we got that. Cool. Now
All right,
let's
so let me do
number
the second one.
Yes, let's please.
All right. Sorry, y'all gotta give me a second here. I gotta
I had to Google chat.
type this one out. Let's see.
I just ran the chat. You had to Google the chance of dying on a regular day. What was that? What's the chance of dying on a regular day?
If I was a 55-year-old woman, it's like 1 in 79,000. So
Okay.
probably a smaller chance for me as a 20-something.
As a
Okay.
27-year-old educated woman, right? Yes, probably a little smaller. Yes.
Yeah.
Yeah. Okay. Thank you for that.
Nice. All right, do you want me to launch this one now?
Yes.
All right, here we go.
So yeah, so now folks, it's $5,000, right? We're not working with the same amount of money. It's $5,000, but it's a 1 in 2,000 chance of dying. What do you do? Okay. Okay, I like it.
All right, I can end the poll.
Yep, and the
All
poll,
right,
please.
here's end the poll, and here are the results.
Okay, there's some conformity here. I like it.
Yeah,
Think
yeah.
about, so the first scenario, right, and we'll get to it. 26% said yes. Second scenario, 29%. So that being said, right, for those of you who wouldn't take the chance, right, to take the recase, the monetary value placed in your life is at least 10 million, right? And we'll see the calculation here, right? At least 10 million. So for those of you who said you wouldn't do it, which is about, there's some conformity there in terms of 74 versus 77, roughly. You're like, y'all value your lives, you're $10 million, like $10 million. Okay, I see you. Right. But for those of you, so I want y'all to think about, for those who and we can't ascertain who this is yet, but think about how you answer these questions, right? Think about if you change your answer in the scenarios, 1 versus 2, it's the same statistical value. It's the same value, right? But how you interpret your assessment of risk is inconsistent. Because you are 10 million, yes, absolutely. It's inconsistent, right? And so do you not see this is the problem how we value alive, and like how we value our own lives, like how I value my life is different from how you value your life, and how I value, life on the street, like, or like random person, right? Random person walking out, like, what's their life, right? Worth, and how we do that in a capitalist society, like, what is that, right? And so there are numbers out there, right? And so FEMA estimates the value of a statistical life to be about 7.5 million, right? I will say everybody in this room that's probably a little more than that before you bring to the table, right? But the point is, there's no consensus on the value of life between people and societies, let alone with ourselves. So if you answered yes and no for these two different scenarios, right, there's an inconsistency within yourself and how you value your own life, right? And so that just speaks to the how hard it is from like a economic evaluation standpoint, how we value a life. It's a difficult thing to do, and it's not an exact science, right? And someone mentioned earlier, like, what's the chance of us dying on a regular day, right? So in scenario one, right, the risk of death was 1 in 100, which is comparable to your chances of dying in a car crash in your lifetime, right? Scenario two, a little less risky, but 1 in 2,000, right? Which is about equivalent to the chance of dying on choking on food, right, in your lifetime, right? And just to kind of put that in perspective, like the odds of I mean, hopefully everyone's a good swimmer here, but the odds of dying by drowning, right? 1 in 98, right? And so, we don't navigate our lives thinking about these risks of death, right? But these are things that we, from an economic evaluation standpoint, we have to think about. We do think about, right? So I know I'm running out of time a little bit here, so I have 10 minutes. And so there's a couple different ways that we use, economists use, I should say, to value a life, and they're not perfect, right? And so there's three main methods, right? And it's just this visual analog scale, right? And so I'm sure a lot of y'all have been in a doctor's office, like, have various conditions, and like they've asked you to estimate your pain, right? And they have different, charts, right, to gauge that, right? And so thinking about like 0 being the worst imaginable health state, which probably, honestly, it's probably death, right? Well, maybe not, right? I just probably think the worse than death, but 100 being the best imaginable health, right? But think about how that scale changes for people, right? Like, if I've never experienced like a very severe disease, my 0 is different from somebody else's 0. My 10 is different from somebody else's 10, right? So how do we standardize that, right? Very difficult. And that's why, and so standard gamble is something we just used, right, in this frog exercise, right, to try to ascertain that using the probability of death, right, versus full health. And then there's this thing called time trade-off, right, which respondents can choose between having X years of health condition, whatever, right, before dying, or fewer years in perfect health, right? So think about, how example that comes to mind is, living with terminal or cancer, right? Versus, and how many years would you want to live with terminal or severe cancer, I should say, versus having X amount of years in perfect health, right? And so you see in the chart here, these all result, right, depending on the state. Look, depression, blindness, deafness, watery diarrhea, all these things, right? Depending on the method, equate to different valuations, right? And again, all this underpins, like, if you never had this state, how do you know, right? And that's extremely problematic in terms of how we evaluate a life, right? And the quality of life. So here's just some extra tools you leave on the side to refer to and kind of lean into. I highly recommend y'all, especially this last one, the guide to the fundamentals of economic evaluation, and how folks in the public health diaspora really evaluate certain interventions. So yeah, I'll leave that there for y'all. I do want to touch upon behavioral economics, right? And this is super intriguing to me, right? Because when we think about economics, right, we always think about these paradigms, these classical paradigms of rational actors who have full information, right? That's not the world we live in. We don't have first of all, we're not rational, and we don't have full information, right? And so we have to make decisions, right, under this context, right? And so we don't make the most rational, optimal decisions, right? And so I think behavioral economics is so powerful because it really leverages the intersectionality of economics and psychology, right, to understand how people behave and act and make decisions in the real world, right? not in these models that we have, we're rational actors and these rational actors want to maximize utility. That's not how we maximize utility in the real world is not straightforward, right? And so, but I think behavioral economics is extremely powerful. And so I don't think we have time to go into breakouts, but I do want to touch about mind space. So this is something I think is one of the more important and powerful slides in terms of like, just remember this, right? And these are things that I think can be used to make better policy, right? When we think about mind space, right? We think about all these different things, right? And how, from a policy perspective, we can incorporate some of these things, right? So whether it's commitment, salience, norms, incentives, messenger, for example, extremely important. And if I'm going to say so I'll put a plug in for HPRS. We were funded, a couple of folks at UCLA who are also part of my cohort. Obviously when COVID-19 happened, right, there was a influx of funding available and to study this, right, and particularly racism. And I think it was extremely important, right? And so one of the things we tested, right, was the efficacy of race conscious messaging on the intent to vaccinate of people of color, people who identify, right, as non-white in LA County. And so we expose people to different messages, right? 3 different types, individual, pro-social, race conscious. And we're really interested in terms of how race conscious messaging impacted the intent to vaccinate relative to the other 2. And so this is where the research comes in, right? And so we use the Likert scale, and we also used vaccine safety belief as the other outcome, and then also the belief of social responsibility to vaccinate. And so, fortunately, unfortunately, whatever it is, right? There was no significant differences in the intent to vaccinate and the belief that vaccine is safe between the 3 public health message groups. And I think this goes back to the mind space of the messenger, and I'm sure folks have seen different messengers, right? On TV, like John Legend had a commercial, different folks had many different people, right? And I think the messenger is so powerful, right? How you translate that message and who it's coming from is extremely important, right? Like it's different if it's coming from Beyonce versus like me, right? Totally different, right? And so I think that was the power of this research in terms of how that message or how race conscious messaging can be effective. Because obviously people of color, communities of color were disproportionately affected by COVID, right? And so to have this trusted source come to you and say, hey, you need to get vaccinated is powerful, right? So we don't have time for a small group breakouts, unfortunately. Time got away from me, but I just hope you all took something from this. And I think, again, when we go back to the mind space, like I'm gonna put it on here, like that's super important because this is something that'd be applicable to whatever discipline background you're in. I think this is one of the biggest takeaways in terms of how we can use these mind space concepts and incorporate it into policy making, right? And so I was gonna have you guys do breakout groups to like think about how one of these tenets of mind space comes up, or how you could think about how it comes up or pops up in policy, right? Or the policy making process. And so but yeah, I'll just leave that there. And I want y'all to kind of ruminate upon how these things can be applicable to the spheres you guys work in. And so I think economics is a powerful tool, and right, and like don't be like it could be a little off-putting a little bit, right? I will say completely anecdotally, right? Economists can be hard to work with, right? A whole bunch of older white dudes who are telling you what can and cannot be done, right? But that's it is what it is, right? But if you could use this and leverage this and understand some of these concepts, you're able to speak a different language and really relate to a different kind of demographic, right? And so yeah, so I hope you all took something away from this. I know time is running out, and so again, this is my hopefully I'll be invited back next year to give this lecture as an alum, and it's my, last time as an active scholar, and it's been a blessing, and just see everybody here, and can't wait to see y'all in 2 months here, and I'm gonna quiz y'all, like, what'd y'all learn? And so, just bring, have an answer, okay? But no, just blessed. Thank you for your time. We have a couple minutes here. I'm gonna give it back to y'all. And let's see the love in there. Thank you. And so yeah, I'm always open. Like I've had different scholars talk to me, reach out about universal basic income, different economic concepts. And so I'm always an open door, and I can't wait to engage with y'all in person. And it's gonna be bittersweet because like I'm out the door, and but not gone, right? And so yeah, thank you for your time. And again, open door. If you have any questions, feel free to email me. Keisha, again, thank you for giving me this opportunity to spit a little bit of knowledge. Hopefully, people took something away. And yeah, thank you.
Great. Thank you so much, Corey. People definitely took something away. You can see all the love in the chat and all the gratitude. So thank you for making time to put this talk together and to share with us. And I hope people certainly took away as much as I did. And also, as you're thinking about your problem statement, and later this summer, we're going to be thinking about those policy solutions. Corey hit on a lot of things today around tax policy, other types of policies. And so think through how some of that information could be useful. So again, thank you, Corey. This was great. Thank you, everybody, for being here. And we'll certainly see you all in, I'll see you in a couple weeks. I guess we'll see you again in a couple weeks for our last session. And then, and as Corey said, although Corey will be graduating officially from HPRS, we never let anybody go. And that's all from a place of love. You will always be part of the alumni community.
You're in, believe that.
That's right. Always part of the alumni community. So thank you so much. And yeah, thank you, everybody. We'll see you again in a couple weeks. Take care. Stay well. Bye-bye.